So tonight we have Piroska Kopar, who joins us from Washington University in St. Louis. Thank you for staying up late. And we'll talk on ethics in the time of coronavirus. And Milana Traunz, who is here at Stanford on pandemic resilience. I'll introduce them one by one. So Piroska will go first. It's up to you, Piroska, if you want to take questions while you go, or wait until the end, and same for Milana later. So Piroska has a background in philosophy and history of science, has conducted research in ethics at Harvard's medical school. I think that's the thing you have in common. You both have been at Harvard Medical School. And is now the director at Univ of the Center for Humanism and Ethics in Surgical Specialties, CHES, at Washington University in St. Louis. If you go to lasertalks.com, you can find the long bios. Okay, Piroska, all yours. If you need to share the screen, share the screen.
All right. Good evening, everyone. Thank you so much for having me. I think this is a very exciting program. I've heard about the laser talks before and seen a few, and I'm very, very excited and honored to be here tonight. Thank you. Just briefly, I want to introduce myself just in the sense of my background is a little bit unusual in that I am both a philosopher, ethicist, but also I'm a surgeon, which is not a very usual combination. And so that comes with its own challenges. I am also an ICU doctor, and so a lot of what I'm going to talk about tonight comes from my experience combining ethics with intensive care. With that said, let me try to see if I can share my screen. I just had to share my screen. Here we go. Screen, icon, whiteboard. I somehow don't see myself as a possibility. Share. I don't know. What do you guys see?
I see your slide, ethics in the time of coronavirus.
Is there a weird green thing on it? Or no?
What is wrong?
No, I just had a strange green thing on top of it. So let me just try one more time. Push up screen, music, basic, desktop. Here we go. Share. Okay. And then let me just put it in hold. Here we go. Okay.
Good. Okay, so I'll mute myself.
Okay. We can't even hear you anymore. I think you succeeded in muting yourself. So I am happy to answer questions. At the end is probably the easiest, but if there's something burning, do interrupt me or write it on the chat. My talk is going to be 15 slides altogether, so you'll be able to bear with me. I don't want to overwhelm you with details. It will be a richer discussion, I think, if I don't. What I'm going to do is I'm going to take the initial considerations and talk to you a little bit about when back in April, when everything started, how we approached the ethical questions in clinical medicine for COVID. And then I want to take a 6 months view of that and then talk to you about what are the challenges that are still coming up that we have absolutely no answers for yet, only some directions. And I'm hoping that you'll engage with that discussion. So back in April of this past year, seems to be one of the worst years ever, we basically just had chaos and panic. There are all these questions that people were asking. Should we go to work even in terms of should physicians, nurses, clinical providers, should we risk our own lives to help patients who come to our hospitals? What about we don't have enough protective equipment? We didn't have enough ICUs or ventilators. There were hardly any tests available. And what about all the privacy issues about patient care? Once we knew that somebody had COVID, is that something that we get to tell other people? What about all the experimental medicines? Should we try them? Should we not? And then some hospitals started just announcing that they will not do CPR or resuscitation on patients who had COVID. So these were the ethical issues that we faced sort of all at the same time in April. And I will go through these issues first, and then I'll address some of the outcomes that came from our approaches. So our ethical approach was to say, COVID-19 is an interesting combination. The situation is a combination really of what we know from HIV and AIDS pandemic as a highly infectious disease. And as far as the resources and all the limitations and how the system was overwhelmed, that really reminded us of maybe utilizing the organizational approach of transplant surgery, where there is a very, very strict allocation protocol. So we were going to take each of these questions that I had just said as issues had arisen and said, okay, let's look at it. Let's look at each of these issues, see what we can learn from the HIV pandemic. What can we learn from organ transplantation and resource allocation? And then let's see if COVID-19 is the same or different, and if so, how, and let's apply the same answers to them. So the very first question we addressed was, well, is there a duty to treat? Do we as healthcare providers have a duty to treat? And the answers, of course, vary. There is some virtue ethicists who will say, yes, absolutely, you always have the duty to treat. And really, when we enter healthcare, we take on an inherent risk. At the same time, it's been well described that there is not really an obligation to perform a suicide mission. If you know that you're going to be greatly harmed by treating someone, there isn't an obligation to do that. So we also slowly learned, and at the beginning, we didn't really know, does the PPE actually work? Does it protect you? So we slowly started learning that it does a pretty good job of protecting you. So as long as you have PPE available, then yes, the duty to treat is there. If you don't have the available PPE, as we often had in the beginning, then you really need to judge for yourself the risk-benefit ratio of the situation. And there isn't necessarily a duty to treat if it amounts to a suicide mission. One expansion that we did is we said, what about the trainees, the residents who are in training? Should they incur the same risk? And to some degree, we argued that yes, because much like professionals who have finished their training, they have graduated from medical school, they have taken on the role of a professional, and so they should assume the same risk-benefit ratio. Patient confidentiality was our next issue that we attacked. And so, of course, the norm is that patients have a right to privacy, and we don't get to tell their information to other people. What are some of the notable exceptions to that? Some of the notable exceptions exist in psychiatry, for example. If a patient is going to tell her psychiatrist that he will later that day harm someone else or themselves, then that needs to be reported. So if there's an imminent threat to the patient or others, then that's an exception. Similarly, much like with HIV, when there is an imminent threat with a life-threatening danger, then that information is not protected by the same rules. Now, COVID was actually easier to share because HIV was, of course, stigmatized. And so COVID did not have that same stigma, which is why I think we haven't really had too much of a problem by reporting anybody's disease state. The next question was, well, who gets tested? And of course, now that we have so many more tests available, this is a lot less interesting question. But initially, it was a very, very small number of tests. So we concentrated on symptomatic patients, then on asymptomatic essential workers, because they are the ones who will spread it to other people. And then, of course, we are now heading into universal screening almost, which is the preferred ideal. Here we get to the really difficult ethical issues of the pandemic, which is the allocation of scarce resources. Before we go into talking about, well, how do we go about doing that? How do we decide who gets what? I'd like to make the distinction that finite resources and scarce resources are not the same. And oftentimes people confuse them. Finite resources are a perfect example is organ transplantation, of course. A given patient who is an organ donor can only give one heart. There is no way to make two of it. So the rules of organ transplantation for allocation are more maybe palatable or more straightforward because there isn't this impetus or a trial of somehow making more of less. The rules are very clear and they are universal within the country. Scarce resources become a little bit more difficult because there is this feeling that maybe somehow we'll get more, and we will get more, but we just don't know when. And that uncertainty, introducing that uncertainty introduces a very different dynamic into the resource allocation. In addition, if you think about it, say you give someone a heart, that heart you will never take back. That's their heart. Not the same with scarce resources. If you put someone on a ventilator, but then you reassess the situation the next day and decide that actually that patient is not benefiting as much from that ventilator as another new patient perhaps, then it's not a final distribution. It is reassessed all the time. So it's dynamic both because there is new resources coming and going, and it's also dynamic because the allocation is not final. With that in mind, there are a number of ways that people ethically are able to argue for allocation systems. One very popular one is lottery. The appeal of the lottery is that everybody is treated equally and that the uncertainties when we don't know if a medication is going to work or not, or is this really going to help or not, the lottery takes that out of the question. That is the big appeal of the lottery. There is the method of having the worst off get preference because there is the law of diminishing or marginal return. As you get better and better off, so for example, the ethical example is if you have somebody who's homeless, to them $1 it means a lot more than to a millionaire. And so that's sort of the idea behind worst off getting preference first. The American Thoracic Surgical Society espouses first come, first serve method. And that is a little bit ethically problematic in that whoever happens to come there first may not be the one who will benefit most. So the Critical Care Society actually wants to maximize total benefit. So immediately two medical societies, major medical societies, have different frameworks on how to allocate these resources. And then Ezekiel Emanuel is a wonderful writer on this subject. And he outlines what I very much think is a great ethical way of allocating resources after maximizing total benefit, which is really based on medical benefit. If you then find two people who are equally likely to benefit, then social usefulness comes into question, which is very controversial. But it's not meant to award people who, I don't know, we somehow think of more favorably, but it's meant to prioritize people whose work then, if they get healthy, can in turn save more lives. So these variations exist and are not at all universally accepted. At any approach to allocation, we argue, has to look at the medicine first. The medical guidelines must be followed first. And so that seems so simple, but it is not what actually happens. What actually happens is people get so panicked in these cases that I'll just give you an example. The threshold to transfuse someone, to give them blood, is their hemoglobin, their blood level. If it's less than 7, then it is medically advantageous to give them more blood. But during the early weeks of the pandemic, ICU physicians were running around saying things like, oh, the hemoglobin is 7.2, thereby not actually medically needing blood. But I'm not going to give them blood because I'm trying to save the resources, save the blood. So somehow there is this this urge to want to suddenly save all resources and somehow just forget the medical guidelines. If we just stick to the medical guidelines, we're actually already saving some of these resources. The second biggest thing is that whichever method we choose, we need to be transparent. If our local community cannot trust us in knowing how we're coming up with our guidelines, that lack of trust is going to have dire consequences. And when we do finally choose that somebody should get something and somebody else shouldn't, because they're maybe not as likely to benefit, or the lottery didn't favor them, then we have an ethical obligation to support them in other ways, whether it's with palliative care or with social services, or just simply being there for them. And then most importantly, just to remind ourselves of the fact that because it's a scarce resource allocation problem, it is a dynamic re-evaluation of the algorithm all the time. And the minute we have a new medication, the minute we have a different quantity of ventilators, we need to look at our guidelines again and again. Which brings us to experimental treatments. People often, especially in the United States, think that new is always better. It's definitely not always better. The therapeutic misconception refers to this idea that people who enroll in studies, so say there's a cancer patient and the traditional methods are not working for that said patient, and they are enrolling in a study. The patient oftentimes is under the impression that they're going to receive medicine and improve from the experimental treatment. Whereas that is not at all necessarily the case. The whole reason that we're researching it is because we do not know if it's going to work. And oftentimes they're very harmful. So the new is definitely not better. It could work or it could hurt you. We just don't know. That's the whole reason that we are researching it. The one thing that came out of the HIV era in terms of experimental treatments is there is a way to fast track FDA approval. So we very much advocated in our statements that anything that you would recommend to patients should be FDA approved, whether it's fast tracked, and maybe have that additional warning, but nothing outside of FDA approval should be professionally recommended. And now we come to this issue of CPR in COVID patients. It was sort of between April and June that some hospitals started just saying, you know what, when we have patients who are COVID positive and they have a cardiopulmonary arrest, we are just not going to offer them resuscitation. So at least 3 ethical issues come into play here. One of them is the idea of futility. Is it futile? One of them is the idea of safety of the provider. And then one of them is resource allocation again, because then of course that's an ICU bed or a ventilator that you would be freeing up if you're allowing this patient to die. So again, we urge people to look at the medical approach first. The very cornerstone of shared decision-making is that the physician recommends the medical treatment and the patient volunteers their advanced directives or their goals. If a care is not going to be beneficial or futile, non-beneficial and futile can be used interchangeably, then that kind of care is never appropriate, whether there's a pandemic or not. If somebody has suffered a heart attack and there is no blood flow to their heart, then we should not give them CPR, whether there is a pandemic or not, because it's not going to bring them back. And it is potentially harming their body. So first, again, figure out the medical part. And second, if there is PPE available, then the providers should be protected. So that kind of reasoning should have died away as that became clear. And then third of all, here is again it's fascinating how often you hear it on the wards that people will say, well, that will free up a bed, or is the reason to let that patient die so that we can help somebody else. And that's not really the place to do that at, because is that really a futile endeavor? 20% of patients who are intubated on a ventilator will survive and come back to be a functional patient. And so futility shouldn't be applied to those particular patients, and the resource allocation should be within the algorithm of the hospital. So here we are now. We are in October, 6 months later. Our new normal is that we screen a lot of people. We do have tests. We have plenty of PPE. And we have certain treatments. They are not cures, but they are somewhat helpful treatments. We use blood thinners, we use this drug remdesivir, and we use steroids. We have better outcomes than we had. Some of the things that came out that I feel like we had planned one way and it didn't work. And one of the things that we hadn't really addressed at the beginning was, what about the mortality from all the other diseases? If we're focusing so much on our COVID patients, what about the other patients? For example, I was on call back, I don't know, in May for surgery and trauma. And I had a 19-year-old patient who came in with perforated appendicitis, with a ruptured appendicitis that was causing her to be septic. 3 hospitals had turned her away already. 3 hospitals had told her that they couldn't take care of her, they couldn't help her because they had too many COVID patients. And so to figure out how to weigh the benefit to the non-COVID patients is just as important. I think the most disappointing outcome from just a strictly, I guess, ethical resource allocation perspective is that none of the hospitals that I know of have been able to actually enforce the allocation algorithms that they have come up with. And the reasons are various. Some of them are legal, and some of them are simply, it is very difficult to get large groups of people to actually follow these algorithms that are changing and that are different from our usual way of practicing. The unfortunate side effect of that is that it's not that we don't ration or allocate care anyway. We just do it non-transparently and not in a standard way, essentially amounting to bedside rationing, which is what we were trying to avoid to begin with. So this paralysis of not being able to carry out our allocation is, I think, the sort of the most disappointing thing from a hospital standpoint, because we had planned for it. We had plans for it and we just didn't follow through. The new challenges, what about patients who refuse to get tested? And of course, along the same lines, when the vaccine comes out, hopefully, what about when people won't want to use them? And what about making public health expectations as measures of law? What if it was illegal? Just like in Italy, you have to pay up to 1,000 euros if you don't wear a mask. Is that something that we should be doing from a public health perspective? I have my thoughts on those questions, but I am very interested in opening up the floor to others and entertain any questions or discussions.
Thank you, Piroska. I have a few questions. you sort of started answering the first one that was about the vaccine. Now, let's assume that the vaccine comes very soon. I'm in favor of vaccines. I believe in the science of vaccines. But in this case, there has been so much political pressure. So how can we know for sure that this vaccine works? I mean, is there some kind of organization that makes sure that ethical guidelines are enforced? How can you reassure us that this vaccine developed in record time is good for us?
That is a true concern. The FDA is supposed to be that body and entity. There is nobody else outside of them. The pressure to have an expedited FDA approval, I think, is worrisome. And I think it's different for a drug. To me, it feels different ethically to give an FDA expedited approval for a medication than for a vaccine. Because when you are giving a medication, the patient is already ill. And they're already they're already trying to get better. Whereas the vaccine, you have healthy people who you may very well hurt. So I think it's not quite the same. And I don't think that it should be fast tracked. I think it should go through the exact same rigorous process as every other vaccine.
Okay. Second question. I mean, you were speaking, you were saying we, and so on. But St. Louis wasn't really the epicenter. I mean, if I think of a place that had to make terrible decisions, probably New York, Italy at the beginning, these places were at one point that they just didn't have the equipment, didn't have the hospital beds and so on. Did you get any input from them? Do we have some kind of repertoire of stories from them, or what was
yes, that's right. So it's funny you say that, because you're right. St. Louis is not the epicenter, and yet we do a lot of bedside rationing, because if you actually we did run out of beds. We did have those issues, and it really had to do with access to healthcare, so that the rural hospitals that were trying to send us sick patients, those patients were disadvantaged who were not physically in St. Louis. So we are continuing to deal with that kind of rationing. As far as places like New York, I was extremely disappointed to learn that not one hospital has actually enacted these algorithms, these guidelines that all the hospitals came up with.
Then you mentioned, at some point you mentioned mortality from other diseases. And I've heard stories of patients who couldn't get health care because the hospital was overwhelmed. And so that's another algorithm that we have to think about, right? By the way, I saw somewhere an article that number of cancers detected this year is much lower than last year. And not because people don't have cancer, just people, can't access the hospital. Now, how does the hospital, the doctor, decide which one to take care first? Now, I can see that COVID is infectious, okay? If I break a leg, it's bad luck for me, but I don't infect anybody else, right? On the other hand, if I have COVID, potentially I can infect, I don't know, 10 people, 100 people, and some of them will die. Is that the kind of algorithm that is used consciously or unconsciously?
So I can only really, because every hospital came up with their own system. One thing that we did in St. Louis that I thought was really wonderful, except that nobody applied it, was several of the major hospitals got together and said, listen, why don't we all work together? We all have a responsibility to our population here, and have similar or the same guidelines, and then we can share our resources and pool them. And with that in mind, we came up with it was vetted and vetted, and we went through it again and again, this series of guidelines on how are we going to look at these patients and decide who is prioritized. And in our particular version of it, we did look at everyone as the same in terms of whether you had COVID or you had some other terrible disease. It was, you were assigned sort of a medical score based on the seriousness of your condition. And that, that score factored into who is going to be looked at as, is this person likely to benefit less or more than somebody else? And overall, I was very much in favor of these guidelines. Everybody at the hospital was. We had plans to, like I said, work together. And then all of that just fell apart because it was just not something that in America you can own, honestly. And to me, that is such a failure of our system to pretend that we can care for everyone and then actually not, but be done on an individual basis.
Now, the face mask, this has been so politicized and it's such a small thing. So I don't know how effective it is.
Just wear it.
Yeah, so I spent so much time in Asia and particularly in China, and people wear face masks even when there's no virus around. So it's not such a big thing. But the reason I'm asking is that sometimes, I mean, this is an ethical issue right now, right? I mean, if you don't wear a mask, you might spread the virus. Mm-hmm. But in some cases, the ethical rule becomes a law. And the simplest example for my generation is the seatbelt. I'm one of the people who refused to wear the seatbelt at the beginning. You know, it's annoying, I don't need it. I'm such a good driver, I will never have an accident. Mm-hmm. And then eventually they decided, no, it's a law, okay? And the smoking, smoking, another good example, no? Mm-hmm. Now, I don't know if the scientific evidence in those cases is so much stronger that overcomes all the discussions about liberty, about, you know. Mm-hmm. But do you think we should think about this I mean, at which point you think the ethical rule should become a law? I mean,
now, yesterday, last month. Yes, I very much agree with you. It's such a small burden. And I think at this point, we have plenty of evidence to show how many lives we could save. And it would cost us. And I think smoking is an excellent example to bring up. I don't understand why it's different.
Okay, final question from me, then I'll read the questions from the audience. Now, COVID is bad. COVID has killed 200,000 people in the US, I don't know, worldwide. So it's bad, no question. So I don't want to minimize it, but there are diseases out there that could be much worse. I mean, Ebola is a way more lethal, right? So imagine if Ebola, we have an Ebola epidemic in New York or in Shanghai, you know. So have you thought about this? I mean, all these ethical guidelines reach an higher order of magnitude when you think of a disease that could be much, much more lethal. And unfortunately, we have to be prepared for worst case scenarios. You know, I keep saying that we tend to prepare only for the best case scenario. So what's your, I mean, have you been thinking about this, that COVID could not be the worst that we have to face?
Yes. Yeah, that's a very good point. I keep returning and sound like a broken record, but I think the biggest thing is that it would be ideal if it was uniform and the whole country had the same allocation approaches, but that's unlikely. So at least on an institutional level, if we could just be transparent and consistent, then people would know what to expect. I always think about this very simple example. When I tell a patient that they can't get something done because it's a Sunday, nobody thinks twice about it. They're like, oh, of course, it's a Sunday. Why, you know, of course. It's just what people are expecting as the norm. If you set up expectations, people understand the system and trust it. So if we could just be transparent with how we are prioritizing things, then I think it would go such a long way.
Yeah, I was thinking of Ebola also because in terms of prioritizing, when you don't have resources, you don't have doctors, nurses, and so on. COVID, in a sense, it's a little easier because there's a section of the population that is more vulnerable. You know, between a 20-year-old and a 72-year-old, who do you take care of first? I mean, you know, statistically, one of the two is more likely to suffer a lot more. If I'm not mistaken, with Ebola, that thing doesn't exist. You don't know who is more vulnerable, right?
Right.
So that, in a sense, with COVID, at least nature helped us find some priorities, right?
Yeah, that's true. That's correct.
Okay, audience questions. You want to read them yourself? Can you see them? You have 3 questions.
Is it under chat or Q&A?
If you move the cursor down, Q&A.
Q&A, got it. From Daniel Cap. My concern regarding future-based social value for allocation of limited resources without taking into account past contributions. Younger patients will have an advantage since they will live longer on the average. Is this a form of age discrimination? Yes, it is and it isn't. It depends, again, on your system. One system says that you should not take age into account. Another system says, and it uses the quality of life adjusted years. And so sort of younger adults are at the height of priority because they've already formed socially into a well-connected social being. So they're actually ethically more important than children, according to this thought. And yet they have all these years to live. So they have the most potential. So again, there are different ways of approaching these resource allocation things, systems, but it's really, to me, about input from your local community and then transparency. Let's go to the next question. Thank you for this brilliant presentation. Oh, that's too nice. What has been put in place to prevent another disease like this from happening? And is the world ready psychologically to receive the vaccine? Thank you. I don't know about the world. I'm ready. I'm ready to take the vaccine. I know that. I don't think much has been put in place to prevent anything else like this. I think that is a disappointing reality of our time, that we are still stuck on bickering over masks. And unfortunately, I don't think there is. Next one, from Mark Ronza, could you please talk more about how the planned adherence to allocation algorithms broke down over time and what was learned? Sure, I'm happy to talk about that. It simply dissipated in this way where, for example, we had 7 doses of remdesivir delivered to our hospital. So we got together and again applied our algorithm to say who is going to get that. And then it's such a large hospital, we have 1,500 physicians. One physician went ahead and gave the drug to somebody outside of this guideline that we decided. Once that happened, other people did it. And then they started saying that, you know, how are we going to defend this legally? There's no precedence. Risk management got involved. One thing led to another, and it just sort of reverted back to how care is usually provided. And people didn't, I guess, stand up for it. There is such a disconnect between the ideals that the hospital's leadership came up with and the actual delivery at the bedside.
Okay, one last question.
Yes.
From RYF.
OSHA said that masks do not work yet. We are not hearing from them in the media. Are they correct? From my experience, I think they work really well. It doesn't even have to be the N95, just a regular mask seems to do a great job. I'm in and out of COVID patients all the time. I think they work really well and they're worth wearing.
Okay. Thank you, Piroska.
Thank you so much.
Thank you.
All right, bye.